You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Rae Norrod, Manager of Oncology Service Line at Kettering Health Network in Kettering, Ohio, and member of the West Central Ohio ONS chapter, to discuss how to safely administer taxane chemotherapy treatments. This episode is part of an ongoing series about chemotherapy administration. The others are linked in the episode notes. Thanks for joining me today, Rae.
Well, hello, Stephanie. Thank you for inviting me.
So to start us off, talking about taxane chemotherapy, can you just tell us about what drugs are included in this category?
Well, taxanes are part of the plant alkaloid class of chemotherapy drugs, which are derived from the yew or the taxus plant. Their main mechanism of action is to inhibit cell division, mostly in the G2 and M phases of the cell cycle. The drugs that are included in this category include docetaxel, paclitaxel, cabazitaxel, and taxols that are combined with protein or albumin particles.
Okay. Well, why don't you start us off with what cancers taxanes are usually treated?
Wow, taxanes are used to treat a variety of cancer types. Some of the more common ones include breast, ovarian, prostate, and non-small cell lung cancer. Among some of the other cancer types include gastric and metastatic pancreatic adenocarcinomas, squamous cell head and neck, and even AIDS-related Kaposi sarcoma.
So a variety of diagnosis, that's for sure, with this treatment.
Absolutely.
So when we're talking about these different diagnoses, are there any particular patient populations that really should avoid these treatments, even if they do have a diagnosis that you may have just mentioned?
In general, taxanes might be contraindicated in pregnancy because there's a risk of fetal harm or fetal mortality. Other people who there might be a contraindication include if they've had a reaction to paclitaxel or drugs like it that are formulated in polyoxyl castor oil. That's a solvent. Sometimes it's a reaction that includes shortness of breath, hypotension, or other things, including urticaria or itching and hives.
Okay, well, thank you for that. So I am guessing that with taxane chemotherapies and also with all of the different treatments that are available now for oncology diagnosis, that taxanes are given in combination with some other agents. Can you talk about some of those common regimens where nurses would be giving taxanes?
Well, sure. As we mentioned, taxanes are used in a variety of cancer types. Some of the ways that taxanes might be combined in a regimen might be docetaxel with 5-FU or with cisplatin. I know docetaxel can be combined with cyclophosphamide or even cyclophosphamide plus doxorubicin. Some of the ones that treat a variety of cancer types include paclitaxel or docetaxel with carboplatin or cisplatin in several different cancer regimens.
Okay, so it sounds like this is one of those kind of gold standard or traditional treatments that we have given for different diagnoses. And in thinking about that, are there any special considerations that oncology nurses need to know when whether it's a monotherapy or in combination? Because there are so many things that nurses need to think about when getting ready and preparing as a patient is, on the schedule, and we look at what their treatment's going to be. And then what do we have to, think about and prepare for in administering these treatments?
Oh, certainly. You're correct. Sometimes taxanes are given as monotherapy, maybe even in a low-dose weekly regimen for certain cancer types. But since we do see taxanes often combined with other chemotherapy drugs, sequencing could be one concern as the nurse is looking at which drug do I give first and why. Historically, myelosuppression seems to be worse when platinums are given before taxanes. There's been some studies that showed a decrease in paclitaxel clearance of up to 33% if the cisplatin or other platinum was given prior to paclitaxel. That could be concerning because then there may be a risk for increased side effects from the taxane. More recently, there actually was an article in the Journal of Oncology Pharmacy Practice about what are the best practices for sequencing in multi-agent oncolytic regimens. They took a look at what literature exists, what's been published, and came up with several recommendations. The ones that pertain to taxanes include giving taxanes prior to platinums because there are several case reports that taxanes may have a vesicant potential. In general, you want to give agents that are vesicants or have a vesicant potential first prior to other medications. And another recommendation would be to monitor. Because platinums often require a monitoring time, it is thought that giving the taxane first and then giving the prolonged monitored platinum second is a best practice.
It's good to know what those best practices are as you're getting prepared. I'm sure some of these treatments are overwhelming for new oncology nurses. And just thinking about, and like you said, some of those treatments are very lengthy. And so making sure that they understand what that sequencing might be and how that would impact a patient and how they respond to the treatment as well. Are there anything that you could think of that would be important for oncology nurses to know about sequencing, or, when there are combination regimens, are there reasons? What are the reasonings behind some of those sequencings orders, let's say?
Well, sure. As I mentioned, historically, one of the things is that platinums can affect the renal tubule or the clearance of other medications. So when a platinum is given, drugs that are given subsequent or after that may not be cleared through the renal system as well and may stay in circulation longer, which increases the risk of side effects. When we talk about vesicant potential, typically they recommend vesicants are given first when the vein is freshest, so to speak, and hasn't already been irritated by other agents, but also because the nurse may need to monitor that IV site carefully throughout the administration to make sure that it isn't leaking or there's not an extravasation occurring. Platinums tend to have the hypersensitivity reactions as well as taxanes, but it's a different type. And because they are often administered over a longer amount of time, the monitoring sequence of giving the taxane first is thought to be better regarding nursing management time and that observation.
Oh, that's good to know. So you mentioned a little bit about infusion reactions. So when thinking about taxanes, what are some adverse events or infusion reactions associated with them? And then maybe talk a little bit about how they're prevented or managed.
So patients may be sensitive to Taxol or to other taxanes, or even to what they are solved in or mixed in as they're being prepared. Because there is a higher risk of these hypersensitivity infusion reactions, nurses will want to be prepared in advance, thoroughly assess your patients, and get a great baseline assessment, including their vital signs, heart sounds, lung sounds, and even their allergy history. Sometimes patients who are allergic or sensitive to something may be hypersensitive to other things as well. Some of the things we often see, it is recommended to reduce that risk of hypersensitivity reactions by pre-medicating. Now, the pre-medications for paclitaxel often include a corticosteroid, such as dexamethasone, diphenhydramine, an H2 antagonist, such as cimetidine or ranitidine, about 30 minutes prior to beginning administration. The pre-medications for docetaxel slightly different. It's usually just oral corticosteroids beginning the day before administration, continuing the day of, and finishing the day after. This has been very effective in many studies as well as common practices to reduce the risk of the hypersensitivity infusion reactions. Other best practices, besides getting that great baseline assessment, is to frequently assess the patient during the infusion, including checking vital signs, especially during that first hour, to see how well the patient is tolerating this. Some of the protocols or recommendations say to also titrate or gently increase the rate of infusion slowly, particularly the first couple of times the patient receives a taxane. And if you notice changes in their blood pressure, heart rate, respirations, or if they're having other more serious reactions, such as angioedema or generalized urticaria, itching, and hives, we may have to slow down and even stop that infusion and perhaps administer emergency medications to stop the reaction. Patients who have the more serious hypersensitivity reactions really should not be re-challenged. Those who are having the more mild reactions, such as a little bit of hypotension or hypertension, may be able to continue to receive taxanes if those resolve within a period of time.
Those are all really good things to know, and a lot of education points, whether that's for the nurses or for the patients and caregivers on what some of those reactions are. And also with the pre-medications, like you were talking about, to really help prevent those reactions, and how important it would be just to make sure that the patients really, really understand how important it is to take those pre-medications beforehand, and then also continuing even after their therapy, like you were mentioning.
Yes. And some nurses have found with, the docetaxel, having the oral corticosteroids begin the day prior, it may be helpful to schedule a reminder phone call just to remind the patient when to start taking it and how to take the oral corticosteroid.
That's a really good point. So I wanted to ask you, we have had an ONS member raise a question on the ONS communities about safe administration of docetaxel and paclitaxel because they are classified as exfoliants that can cause inflammation and potential for tissue necrosis. How can infusion nurses safely administer exfoliants?
Oh, this is a great question. I know I've heard some confusion of the terms here too. For those who aren't familiar, an exfoliant is capable of causing inflammation and peeling of the skin. It's usually less likely to cause underlying tissue death or damage like the true vesicants do. Our taxanes have exhibited some properties of a vesicant, but typically what we're seeing with injection site reactions, even during extravasation of a taxane, is usually mild. The patient may get redness, tenderness, skin discoloration, or swelling along the vein or injection site. In studies, as well as in clinical practice, we've seen that the more serious events, like phlebitis, cellulitis, or even tissue necrosis or tissue fibrosis, tend to increase or be more common if the taxane infusion is more concentrated as it's being prepared in solution, or if it's being given as a prolonged IV infusion. For example, there seems to be a greater risk for recurrence in the 24-hour infusions versus in the 3-hour infusions. Some things nurses can do to help maintain patient safety regarding this vesicant or exfoliant potential for damage is to work with their institutions and with their team to make sure that taxanes are prepared at the recommended concentration. Since the more concentrated solutions tend to have a greater risk, working with their pharmacist and others to make sure they're at that proper concentration reduces that risk. Also, working with their team about how long they're infusing the taxane. Remembering that the longer or prolonged infusion times appear to have the greater risk, maybe the 3-hour infusions should be preferred over the 24-hour infusions. Or if the patient really does need to have a prolonged infusion, are we using the best vein? While you could infuse that peripherally, perhaps it might be better to use a PICC line, a port, or another central venous access device in those specific situations that the infusion will be longer, or if the patient maybe has veins that are irritated or otherwise compromised. And then having procedures in place for the nurses. Do you know what to do if a vesicant or a taxane does extravasate or infiltrate? Do you have something that already is in place to guide you as far as things like stopping the infusion, assessing the site, how you notify the provider to see if they have additional orders or recommendations to reduce the tissue damage and the risk of tissue necrosis?
Thank you, Rae. That was very informative. And I think if that member is listening, that was really great information on that. I have another question from the ONS communities. A member asked about preventing hand-foot syndrome, nail changes, or neuropathy by using ice packs. What does the research say about cryotherapy? Are there recommended processes for using ice packs?
Wow, I know this is kind of a hot topic. There are many questions about cryotherapy right now. The idea behind cryotherapy or extreme cooling is that the cold constricts blood vessels and then would reduce exposure of those tissues to the cytotoxic effects of that chemotherapy agent. So the cryotherapy may reduce incidence as well as severity of certain side effects where the cold is applied, such as peripheral neuropathy, hand-foot syndrome, and nail changes in the extremities. There have been a few studies examining using frozen gloves and frozen socks on patients that has shown some early promise. Right now, cryotherapy has shown success and has some effectiveness in reducing oral mucositis with specific chemotherapy agents, as well as with alopecia and the use of cold caps to reduce hair loss. But some of the concerns that arise with using cryotherapy for extremity cooling might be that because we're reducing by vasoconstriction, reducing the exposure of tissues to chemo agents, what would happen if some cancer cells are left behind because they're in the tissues that are being frozen or less exposed to the chemo agent? Other concerns are there are certain patients who can't tolerate extreme cold temperatures well. Some of those patient populations may include Raynaud's disease, peripheral vascular disease, and patients who have cold hypersensitivities from oxaliplatin treatments. There was an article in early 2020 in the Clinical Journal of Oncology Nursing, which is an ONS publication, that explored the existing research on cryotherapy for peripheral neuropathy, nail changes, and hand-foot syndrome, and showed that there is that early evidence or early promise that cryotherapy might be able to help prevent or at least reduce the toxicities with nail changes and peripheral neuropathies. But they concluded that larger studies are still needed. So for now, they recommended that clinicians carefully weigh the risk versus benefit for specific patients that seem to be the most appropriate to try this therapy.
It's really good to see that there is research being done on, these, like you said, hot topics in question about the different ways that we can try to manage some of these side effects for patients and really do so that they can have a better quality of life and still get the best treatment that they can. So we've talked a lot about how taxanes are administered and the reactions or management of side effects that patients may have with that. And now I'd like to talk a little bit about safety concerns for patients and providers. So how can just in general, what are some of the safety issues or what can nurses do to maintain safety in chemotherapy administration?
I know in general, you can look to some guidance and guidelines. Oncology Nursing Society has some scopes and standards of practice that do guide safe oncology nursing practice. For example, the ONS position statement on the education of the nurse who administers and cares for the individual receiving chemotherapy, targeted therapy, and immunotherapy supports that nurses who are going to administer and monitor these patients should have some specialized education, of course, about cancerous disease processes, but especially about the drugs themselves. There are more than one kind, or there is more than one kind of chemotherapy drug. They have different mechanisms of action. And now we have these newer drugs. Lots of immunotherapies and targeted therapies are now on the market and are coming into our everyday practice. It can be a challenge to keep up with what these are, how they work, how to administer them safely, and how to monitor our patients and work with them to reduce their side effects and to keep them safe. The ONS guidelines also recommend that nurses have a clinical practicum after they complete classroom on this content so that they're working with experienced nurses to make sure that they are following good standards of practice or best practices in chemo administration and in the patient assessment and monitoring that follows that. In general, annual competency is also recommended to make sure that the nurses are staying current and following those best practices.
It is so important to understand what the best practice and the guidelines are. Like you said, there are so many treatments out there, and, not only, our traditional chemotherapies, but all of the new therapies that are coming out. It's so many and so fast, and to have resources that nurses can go to look at what those safety standards are and things like that is so important. Are there any additional training or any additional education that oncology nurses would need to specifically administer taxanes?
Well, there are several additional things about taxanes that might be special or different than other chemotherapy agents or anti-cancer agents. One of those would be plasticizer DEHP is present in the taxanes as they're being prepared. And this may be leached out of the PVC infusion bags or tubing sets. So preferably, taxane solutions are prepared in glass bottles or polypropylene and then administered through polyethylene line administration or tubing sets to reduce that risk. An inline filter of 0.22 microns is also recommended for them. Other safety considerations with taxanes are that they actually are NIOSH Group 1 hazardous drugs by definition, which means they're cytotoxic or cell-killing, as well as hazardous to both males and females who are actively trying to conceive, women who are pregnant or may become pregnant, and women who are breastfeeding. According to OSHA, all personnel who may come in contact with hazardous drugs need to receive safe handling education in order to protect themselves and others from exposure. Employers are encouraged to have training as well as policies and procedures in place to guide staff as they're working with these drugs.
That is important to know. And wow, as I just said about all the different and new drugs and having to understand and learn about those, and then to have something like a taxane where you have to have special administration kits with special tubing and the filters, like you said. Those are all really important things and an added reminder or an added thing to remember when you're administering.
Yeah, there's a lot to remember. And I just see the benefit of the nurses I've worked with who said they appreciate, even the ones who have given chemotherapy for many years, if they had not had the opportunity yet, they actually come into classes or training later and say, wow, there's things that I didn't understand before that now I know why. we need to follow that as a best practice.
Definitely. And, I just feel like, in oncology, we are just continually learning and learning more about, the treatments and about the symptom management and side effects that go along with that, and how we continue to do that, and how it definitely continues to improve our patient outcomes and their quality of life during this difficult time for them. So we're coming to the end of our podcast, and I have a few questions that we like to ask everyone. And the first one is, what are some common misconceptions about taxanes?
I think a lot of those I have found come from working directly with the patient and maybe with support person. But that's important because as nurses, we have the opportunity to help them understand their treatments better. Some of the common myths that I've heard a lot of is our patients seem to think that every kind of chemo makes you very sick at your stomach and you're going to throw up the entire time you're receiving the drug. It's good to know that taxanes tend to have a lower emetogenicity potential, around 10 to 30%. So some patients may require only a daily antiemetic or maybe no antiemetics at all, depending on other risk factors. And that can be good to know. Sometimes it is the patient's own worry or concern about how they're going to feel on chemotherapy that may even prevent them or make them refuse treatment altogether. So being able to talk to them about how they're going to feel on chemotherapy and what will their quality of life be like on those treatments is really important. While all chemo does have some side effect, every drug does, usually chemotherapy side effects are temporary and can be well managed. So as we're talking to them about, well, what do you understand and what do you need to know? When your patients say they're afraid to take a taxane because they think they're going to feel sick or unwell, I refer to one of our studies about gentlemen who are receiving docetaxel for advanced prostate cancer. In that study, they actually reported they felt better on the docetaxel therapy and had higher quality of life scores than they did prior to beginning treatment. So what I'm trying to say is some of the taxanes are not so difficult to take, and the side effects are temporary and can be well managed. One of the other myths that I've often heard is, well, that chemo doesn't work. I have to get one of those new immune therapies or targeted therapies, or my cancer will just continue to get worse. And I want to say, well, that's not exactly true. In fact, we have many years of supportive evidence that chemotherapy does work, and it can be very effective at reducing cancers and even helping people enjoy long disease-free survival intervals. But because chemotherapy doesn't work for every type of cancer, that's why we continue to study what's a better combination of chemotherapy agents, or even as we've learned more about how cancer cells differ from normal cells, we've begun to get some of these new therapies like targeted therapy and immunotherapy in the hope that we get an even better response rate or disease-free interval, better survival for our patients.
That was a great answer. So my next question, what patient and caregiver education should oncology nurses provide?
Patient education is key. There's been several reports and studies that when your patient is engaged and understands the treatment they're receiving, that not only are they more likely to let you know when they're not feeling well and need help with symptoms and side effects, but also they are also better able to engage with you and perhaps prevent an error from happening, such as the wrong dose or getting a drug at the wrong time. Basic chemotherapy education should include that patient as well as their caregiver or significant other. Things like a drug information sheet. What is paclitaxel? What does it do? What are its common side effects? And then reviewing those common or anticipated side effects, especially, things like myelosuppression, nausea and vomiting, alopecia, peripheral neuropathy. and hypersensitivity infusion reactions, and then talking to the patient. What can you do at home if you are having nausea? What can you do for yourself if you have concerns about peripheral neuropathy? Versus when is it severe enough, or what kinds of questions should you call and get further help from your oncologist and your oncology support team for help with those symptoms and side effects. I think the patient education process is also a great time to look at patients' other needs. Does this patient have risk factors or needs that show you they might benefit from talking to your financial counselor, social worker, dietitian, or other team members to make sure not only that their needs are met, but perhaps give them a better chance of getting through their treatment safely and successfully, instead of perhaps missing appointments or delaying their care.
Very good. It's so important to get that good education to both the patient and the caregiver. And like you said, it just helps to have an engaged patient so that they understand and can help themselves and help you as they're getting their treatment. Next, what are something about taxane chemotherapy treatment that's not often discussed, but you wish people knew more about?
Well, I know, goodness, we've talked about a wide variety of topics on taxanes. Back at the beginning, we were talking about taxanes are used in such a wide variety of cancer types and in several combinations. We're administering them so often that we kind of take them for granted. We think, oh, yeah, I do that all the time. So it's important to pause and think, regardless of how many years you've administered taxanes or how often you give them, and reflect on, am I thinking about the potential for exfoliant and vesicant properties by using the right vein and being safe during the administration? Am I making preparation for assessing the patient thoroughly to help reduce the risk of hypersensitivity reactions? Did the patient receive the right pre-medications to reduce that risk? And am I just checking their vital signs frequently and checking the patient to see how they feel during that infusion, and perhaps picking up on a reaction quickly or early and being able to intervene quickly? And then am I taking the time with each cycle or each administration to circle back to the patient about what questions they have? Did they have any difficulties with their symptoms or side effects on the last cycle that we need to address before we proceed with the next dose? And then taking the time to address their concerns and maybe connect them to more resources, depending on what they say.
Great. Well, speaking of resources, what are some resources for patients and providers who want to learn more about taxane chemotherapy?
Well, we've mentioned a couple during our time together today. That ONS has published several articles in the Clinical Journal of Oncology Nursing and has featured things like cryotherapy during 2020 in the ONS Voice. And they also have great books that we can talk about, including the chemotherapy and immunotherapy guidelines and recommendations for practice. That book includes not only basic chemo caveats and safety, but specific information about taxanes and the most common side effects like myelosuppression, peripheral neuropathy, and best practices for helping the patient manage those. When you have a patient or maybe a nurse who wants more information, the National Cancer Institute website at www.cancer.gov also specifically outlines paclitaxel, docetaxel, and other taxanes. And they have language that's appropriate for both nurses and for patients available. The package insert that comes with the drugs is also a great reference. And if you have a pharmacist or pharmacy team that supports your infusion area and your chemotherapy preparations, often they know more about the specific drugs or specific side effects, or can get that information for you. So I just encourage you to use the references available, to check out great standards and scopes like ONS, reliable websites such as the National Cancer Institute, to find out more.
Thank you. I just want to thank you, Rae, for all of your information that you shared with us today. And I think this is going to be extremely helpful to our listeners and those that may be new to oncology or maybe just need a refresher on taxane. So thank you for that. Do you have any final comments before we go?
I just wanted to say thank you so much for having this discussion today. Oncology is kind of a team sport, right? Talk to your team members, work with the other nurses, the pharmacists, the oncologists on your team, and we can together create safe practice and a great patient experience.
Thank you.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.